Thanks to join this webinar thing. I'm tasked to talk about chronic obstructive pulmonary disease. Basically, how to manage this, how to diagnose, and when to suspect and think about your patient with COPD. Okay, I can do next slide. Next slide. Oh, COPD is defined as a common and preventable and treatable COPD is defined as a common, preventable, and treatable disease. Is characterized by a persistent airflow limitation that's usually progressive and associated with an enhanced chronic inflammatory response in the airways and lung to noxious particles or gases. And exacerbations and comorbidities contribute to the overall severity in individual patients. I'll be using the word GOLD here, and GOLD really is the Global Initiative for Chronic Obstructive Lung Disease. This was actually established back in 1998 as a collaboration between the National Heart, Lung, and Blood Institute in the United States, the NIH in the United States, and the World Health Organization to focus on COPD. The first report of GOLD was done in 2001, and since then, yearly updates have been made. Comprehensive updates were done in 2006 and 2010, and the latest update was just done this year. When we think about COPD, it's a big global health problem. It is right now the fourth leading cause of death worldwide, and by the year 2020, it is estimated to become the third leading cause for death. And prevalence study in study published in 2007 showed that about 10% of the population would have airflow limitation, which would be characterized as whether it's moderate to severe COPD. And this was done in multiple international sites. And in the United States, the death rate from COPD has increased over the last 30 years by over 100%, 102 counting mostly for the cause of the increase. How about here in the Philippines? What's the state of COPD? As of present, it is the fourth leading cause of death in the Philippines. And in the same BOLD study, which was published in 2007, BOLD released the burden of obstructive lung disease. It is about 14 in Manila would have COPD. There was a study which was published in 2011 done by several pulmonologists, one of whom was Dr. Roa, who's part of our reactor in this session. And it's about 20% in two rural areas in Nueva Ecija, two towns in Nueva Ecija. And unfortunately, only about 2% of these cases are diagnosed by doctors. And not only that, even once diagnosis is made, there's a high prevalence of undertreatment of the disease. And the most common cause of COPD in the country is still cigarette smoking. Unfortunately, the smoking rate in the Philippines right now, prevalence is about 28%. And this is still on the rise, unlike those in first world countries, which now the prevalence rate of smoking has dropped to less than 20%. In fact, in the United States right now, it is at its all-time low of 16%, whereas here in the Philippines, we're up to 28%. And the prevalence of secondhand smoking exposure, including that we get from riding the bus or the trains, is up to 55%. Use of firewood for cooking, charcoal, farming, where we usually burn the crops after harvest, and a history of TB have been associated with COPD in the Philippines. The question is, why do we treat COPD? What is it? Why is it that something that have to be diagnosed and treated? Because COPD increased. Among those with severe COPD, up to 40% would have died in 3 years, and unfortunately, the burden of comorbidities would actually make this a huge problem for the community and the country, not only for the person itself. COPD caused by environmental tobacco smoke, it's a huge problem. And when you talk about environmental tobacco smoke, it refers to exposure from tobacco smoke from someone else's cigarette. So it is really the material in the indoor air that originates from tobacco smoke. And the higher the exposure to the secondhand smoking, we commonly know it, it's associated with a greater risk of developing COPD. And in fact, women married to smokers who smoke more than one pack a day has a 2.5 times greater risk for developing COPD. So what is the key risk factor for the development of COPD? Well, it's the cumulative exposure to noxious particles, the constant exposure for it. The most common would be cigarette smoking. You could have secondhand smoking, otherwise known as ETS, environmental tobacco smoke, occupational dust and chemicals, and indoor air pollution, basically the use of fuel like fire, charcoal, firewood and charcoal, which is really, unfortunately, a very common problem in third world countries. So what are we talking about when we talk about biomass fuel? Worldwide, especially among third world countries, we have a very high use of wood, charcoal, vegetable matter, and animal dung. And about 50% of COPD deaths in developing countries are really from biomass smoke. And these are really mostly women who do the cooking. And this exposure has an increased association with the development of chronic respiratory tract infection as well as COPD. And the most polluting really are dried animal dung and scavenged twigs, because these are cheap, very inefficient, and most highly polluting. How do you diagnose COPD? Well, the key indicator to consider is number one, these patients dyspnea or worsening shortness of breath over time and with exercise is the most associated with chronic production. Then you will get a history of exposure to risk. Most of these patients smoke. They use biomass for cooking or heating, or they had exposure to dust and chemicals. And we cannot negate that there must be some predisposition to COPD because there's family history of COPD. When you have the symptoms, the history, you need a spirometry to diagnose COPD. And COPD is defined as a post-bronchodilator FEV1 over FEV ratio of less than 70%, which means that there is persistent airflow limitation. And we're going to go through again what we mean when we talk about an FEV1 over FVC ratio of less than 70%. As again, let me emphasize, to make a diagnosis of COPD, aside from the symptoms and the history, a spirometry is required. The most common problem we have to face is how to differentiate between COPD and asthma, because they may actually have sort of the same history and same symptoms. When you talk about COPD, the onset is usually midlife, in your 40s. The symptoms are slowly progressive. There's almost always a smoking history or exposure to occupational stuff or indoor pollution. There's dyspnea almost always during exercise. And when you do a spirometry, it's an irreversible airflow limitation. On the other hand, asthma, the onset is usually early in life, childhood, teenager, under 20s. The symptoms vary from day to day. Symptoms usually may be more common during the night or early in the morning. There's other symptoms of atopy, allergies, rhinitis, eczema, otherwise known as skin asthma. There's a family history of asthma, and when you do a spirometry, there is a reversibility in the airflow limitation. The new thing now to recognize is that it's not really new. It's been described actually since 2007. A good number of patients with obstructive airways dysfunction is what we call the overlap syndrome. They have signs and symptoms both of asthma and COPD, and this is the the clinician will find it hard to distinguish whether it's really asthma or COPD, even based on current diagnostic tests. And that's what we call now an asthma COPD overlap syndrome. In fact, a recent review article, which was just published in the New England Journal of Medicine, estimated that up to 15 to 45 of patients with obstructive airways dysfunction will have the overlap syndrome. And as you can see in the table, you have here a thing where you have patients with easy asthma. Easy asthma is your current typical asthma. Patients with easy COPD, the prototype COPD, and then the last two columns are your ACOS syndrome, wherein the third column is ACOS stemming originally from asthma, and the fourth column is the overlap syndrome stemming initially from COPD. So if you look at this, those with typical asthma, otherwise known as easy to diagnose asthma, the age of onset is usually very young, under 20s. There's the presence of atopy, meaning allergies. They usually never smoke, and the dyspnea is not consistent. It's recurrent. It can be sometimes in the morning, sometimes at night, but they have periods of being normal. Wheezing almost invariably can be heard, and when you do a pulmonary function test or spirometry, it is reversible. And then there is bronchial hyperresponsiveness, which means that they do very well with inhaled anti-inflammatories. Patients on the prototype COPD, on the other hand, these are the ones which are easy to diagnose. They're usually older. They're usually smokers. They have really no history of allergy, and they're usually heavy smokers. Dyspnea is not intermittent, it's chronic. And usually, if they're not having an exacerbation, you don't really hear the wheezing. The reversibility in the airway is not there, and there is no bronchial hyperresponsiveness. On the other hand, as asthma progresses, they can develop features similar to COPD. Then they develop the overlap syndrome. And in this case, they now have a chronic shortness of breath with flares in between. The airway reversibility disappears, but there is still bronchial hyperresponsiveness. On the other hand, patients with COPD can develop asthma-like features where they have flares, chronic with flares, they have wheezing, there is some bronchial hyperresponsiveness, and there's some reversibility in airway obstruction. And if you think about it, estimate of 50 to 45% of patients would have this. When we talk about COPD, we have to think of other things. Again, differential diagnosis of COPD. As I mentioned, asthma is the most common. Things to consider, especially patients with COPD have a lot of comorbidities. Congestive heart failure is something you have to consider. And in congestive heart failure, you will see more of a restrictive lung. The volumes are small. X-ray will guide you. Bronchiectasis are usually more associated with recurrent bacterial infection, and your X-ray and your CT scan will help that. TB has to be considered, and the rarer differentials would be obliterative bronchiolitis, which you see in younger patients, or panbronchiolitis, which is usually associated with chronic sinusitis. Again, the most important thing, aside from the signs and symptoms of your patient, you need a spirometry to make a diagnosis. It is the most reproducible and objective measurement. On the other hand, question is, can we use the peak flow to diagnose? And the answer is it cannot reliably diagnose, even though because its sensitivity is high, specificity is actually low. And COPD diagnosis is made when the post-bronchodilator ratio is less than 70%, meaning the patient cannot exhale totally what it inhales because of the obstructive dysfunction. And that's COPD. Very important to emphasize, we do not advise screening spirometry. Spirometry is only done in symptomatic patient. It is not like a mammogram that you screen. You do not do a spirometry if the patient is not symptomatic. And this is your classic spirometry finding in a patient who's normal and the patient who have COPD. As you can see, this is your inspiratory loop, And this is your expiratory loop. And in a normal patient, the expiration is smooth. You can see the smooth line. In patients with COPD, because of the obstructive airways, there's a scooping in the expiratory limb because the flow goes down as the volume in the lung decreases. And this is the numbers you're interested in. FEV1 is the amount of in liters the patient can exhale as against of how much she can forcibly inhale. And in normal patient, about 80% of what's inhaled can be exhaled that second. However, in COPD, it's always less than 70%, meaning a lot of the air gets stuck in. As you can see again, there is that problem in exhalation. And what do you say? What is normal then? Well, in fact, there's already tables of what's normal, FEV1 and FVC. Most of these are in Caucasians. And Dr. Roa and company, again, back in 1987, published the normal standards for Filipinos, and you can actually easily download this in the web, which was published in 1987, was republished in 2013, and this is based on the age and height and the gender of the patient. There's an expected normal FEV1 and FVC, and again, easily downloadable in the web. Now, when we talk about COPD, now we talk about spirometry and its classification. Again, gold, which is really the one leading us in taking care of patients with COPD, diagnosed by spirometry, the staging. We have a stage 1, stage 2, stage 3, and stage 4. Basically, the most important thing to start with is that all the ratios of FEV1 over FVC is less than 70%. Once it's less than 70%, you now look at the amount of air that can be exhaled in a second. And in mild COPD, they're able to exhale 80% of the predicted. In patients with moderate disease, it's between 50 to 80. In patients with severe disease, it's less than 50, but more than 30%. And in patients with very severe COPD, it's less than 30% of predicted, or if it's less than 50 but chronic respiratory failure, that's considered severe COPD. Now, when you categorize a patient with COPD, you put together the spirometry grade plus the symptoms. And patients are graded as to group A, B, C, and D. Group A patients are those whose PFT is in the 1 or 2, less exacerbations, and very little symptoms. Group B patients, they're still in category 1 and 2 in their spirometry, but they have more symptoms. Group C patients, spirometry are the moderate and very severe, a lot of exacerbations, but the symptoms are not standing out. And group D patients are on the very severe obstructive dysfunctional spirometry, lots of exacerbation, and very symptomatic. And when we talk about symptoms, we actually can use several scoring systems. The one that's easily used is the MRC Dismal Scale. Basically, all of us can easily remember this. Grade 0 is basically no symptom. Grade 1, breathless only on vigorous exertion. And 2, 3, 4, 5 as the symptoms worsen. Anything grade 2 or higher is considered significant symptoms. So other tests to consider when you're diagnosing COPD, check X-ray or CT scan because you have to rule out other pulmonary comorbidities. Basically, lung cancer is a concern because patients with COPD have also high risk for lung cancer because basically they share the same risk factor, which is smoking, and we believe the presence of COPD may not actually help us remove some of the carcinogens that we actually inhale. We can also include, which is done in a more complete PFT or diffusion capacity. We have to consider doing oximetry and arterial blood gas if your FEV1 is less than 35. So anybody with a more severe to very severe category in the spirometry. Exercise testing can be considered, although we usually don't do this. And very important to test for other comorbidities, coronary artery disease, congestive heart failure, and osteoporosis. In patients with gold category 1, 2, 3, and 4, 3-year mortality increases the more severe that spirometry is. So in the gold 4 category, very severe, up to 25% will not be around after 3 years. When you have now diagnosed your patient with COPD, what are your goals for your COPD? Well, reducing the symptoms, which means relieve the symptoms, improve the exercise tolerance of this patient, and improve the overall health status, and reduce the risk for mortality and worsening of life, which means prevent disease progression. Very important, treat and prevent exacerbations, and again, reduction of mortality. Now we go to pharmacological therapy for COPD. As I mentioned before, you categorize your patient to group A, B, C, and D. Group A are low-risk patients, PFT, an FEV1 of less than 80%, but fewer symptoms. The current recommendation is to consider acting muscarinic antagonist or short-acting beta-agonist. So no maintenance meds. This is the recommendation first line. And we will talk about later about maybe the difference now on approaching patients with this. B patients were in low risk but more symptomatic. They would now need a daily maintenance long-acting bronchodilator, whether you're going to consider LAMA, word LAMA. These are your long-acting muscarinic antagonists. When we're talking about LABA, long-acting beta-agonist. So low risk, more symptoms, once a day, LAMA or LABA. In your patients who have higher risk, meaning FEV1 less than 50 but greater than 30 with fewer symptoms, you can consider combination inhaled corticosteroid with LABA or LAMA, or now a combination of LAMA and LABA. And your patients with high-risk patients, this is when the triple therapy may be considered. When we say triple therapy, LAMA, LABA, and inhaled corticosteroid. However, in the current code 2015, idea of maybe going into an alternative choice with better control is going into play. So even in group 1 patient, consideration now of starting them on a once-a-day bronchodilator is being considered, which means LAMA or LABA, and then your rescue with the short-acting bronchodilators. Other possible treatment would be theophylline, but this is now going to be in your group B patient, a once-a-day bronchodilator, and your alternative choice now may be more of a combination of your LAMA and LABA, and then alternative therapy would be your as-needed short-acting beta-agonist or anticholinergics. In your more severe patients with less symptom, your option is again a combination of LAMA or LABA or ICS with LABA, or you now can consider adding on a phosphodiesterase 4 inhibitor. And again, short-acting beta-agonists or anticholinergics. And in the most severe category, this is when you have a combination of LAMA or LABA plus inhaled corticosteroid plus your phosphodiesterase inhibitor. And you can consider adding on acetylcysteine, theophylline, and again, short-acting beta-agonist. Okay, this sounds like complicated, but it's actually not. It's actually pretty simple. We have to think about the thing with COPD is we're flooded in the market with 10 million things. What do I do? What's the first line to do once I have diagnosed? Because anyway, in the market now, as you can see, you have a lot of short-acting anticholinergics. You have the combination beta-agonists and anticholinergics, and the combination of long-acting beta-agonists plus steroids. And again, the agents for combination LAMA-LABA are now coming out into the market. So as you can see, you now have this array of options, and the question is, what will I use for my patient? Which one? Remember that the beta-agonist and the muscarinic antagonists work in different areas. The anticholinergic agents really work more in the proximal airways, and your beta agonists work more in the peripheral airways. And basically, both of them will produce bronchodilation in different pathways. So the question is, which one should I use? Let's just start with your rescue medicine, the short-acting inhalers. Which one should I use if I need something emergently? If you look into this data, which was published back in 1999, always actually reverse with either salbutamol, albuterol, or even the most combination. So most would respond. So any of this will be good. We start early. And the question is, which one should I use? Long-acting muscarinic antagonist or the long-acting beta agonist? What are the adverse side effects of your LABA? Will come and dryness of the mouth and some bitter taste. If you have a question, which one will cause an increase in your FEV1, there's really no difference between your and your LABA. So there is really no difference in the FEV1 improvement between LAMA and LABA. So when do you consider, you've decided you will use either your LAMA or your LABA, maybe considerations to think about, if your patient will be a better option than LABA, okay? Get your red treatment, exercise, will increase in patients given acting the combination gave the highest improvement the FEV1 in patient as a single. And again, question is, where is this improvement? It is the combination LAMA or LABA or the combination of inhaled steroid plus LABA. And as you can see in patients with COPD, we're not talking about asthma, the increase in FEV1 was highest in the LABA against the LABA ICS. And no-brainer because two bronchodilators will be better than one, especially they work in the different very effective in preventing database review in 2012, and all of these favor again using important compare labas for time of first activation combination CS with the llama inhalations or inhaling ice. This was steroid, the higher the risk for pneumonia. LAMA or please step up if you have more symptoms of asthma or COPD such as asthma. Important that smoke to be off your varenicline, have varenicline in the country. And this should be part of it always. As when you're smoking, almost as you're smoking, you have to advise strongly patient to quit in a very strong manner. Say always if she's smoking, see and counsel your patient. How about vaccines? This is a must for your patients. COPD have been shown to reduce exacerbation both pneumococcal vaccine, influenza, and influenza vaccine as a mortality advantage against all without vaccination. How about pulmonary COPD? Very important. There's exacerbation, decrease unplanned hospital when you put these patients on pulmonary rehab, and it benefits not only the severe category, even the mild to moderate will benefit. It reduces symptoms, very common PD because other message improves their quality of life. And this can be provided as an outpatient therapies to consider once the patient reaches the very severe category, saturated with number, then you have COPD whose carb volume reduction. And these with the overlap, treat more with an ice to actually swallow the spiriva instead of putting it in the inhalers. So you have to make sure your patient is They're in, can enroll in pulmonary rehab program, please do so. Walking, increasing physical activity